Today, we are peering into a subject that is, well, it's simultaneously commonplace and profoundly mysterious. General anesthesia.
It really is.
We are talking about the drugs that allow us to undergo life-saving, life-altering surgery by inducing this completely reversible state of unconsciousness, sensory loss, and immobility.
It's the closest thing we have to controlled temporary biological suspension. It's a modern miracle, really.
It is. And our mission for you today is to get a real handle on this. We want you to quickly master the mechanisms, the history, the critical stages, and, the huge arsenal of tools that modern anesthetists actually use.
We're going to move far beyond that simple idea of just being put to sleep.
Right.
We want to help you truly understand the pharmacology behind the 4 essential cardinal features that define what successful general anesthesia even is.
Okay, let's unpack that, because general anesthesia isn't just one thing, is it? It's a simultaneous achievement of 4 very, very distinct physiological goals. So what are these non-negotiable requirements for a procedure to be carried out safely?
They are, you could say, the pillars of safe surgery. We absolutely must achieve all 4, and they have to be reversible.
Okay.
The first, and maybe the most obvious, is the loss of all sensation.
No pain.
Exactly. The total abolition of pain. We call that analgesia. Second, and this is just as vital, is achieving sleep, unconsciousness, and complete amnesia. The patient must not only be unaware, they must have 0 memory of the procedure. None whatsoever.
So we need to block the pain signals from ever reaching the brain and make sure the brain isn't recording anything that's happening.
Precisely. Third, we require immobility and muscle relaxation. Any sudden movement, even a tiny twitch, could be catastrophic during a delicate surgery.
I can't even imagine.
And finally, and this is one people often overlook, the drugs have to cause the abolition of somatic and autonomic reflexes.
What does that mean in practice?
It means preventing the body's own dangerous responses, like a massive spike in blood pressure or heart rate that would normally be triggered by the incredible trauma of a surgical incision.
When you lay those 4 goals out like that, the historical context becomes horrifyingly clear. Before these breakthroughs, surgeons were basically just fighting a losing battle against the human body's natural responses.
Oh, absolutely. Before the mid-19th century, surgery was, and I'm quoting here, a horrible ordeal.
I believe it.
Just imagine the scene. Patients were often held down, physically restrained by strong assistants. The surgeon was timing the procedure by the clock because speed was literally the only tool they had to minimize suffering.
And they tried things to dull the pain.
They tried everything. Alcohol, massive doses of opium, cannabis, even physical methods like concussion, knocking the patient out, or inducing near asphyxia.
Wow.
All of them were largely ineffective and, frankly, utterly cruel.
That puts the timeline of the scientific breakthroughs into such sharp, dramatic relief. The shift from a screaming, restrained patient to someone in a state of controlled unconsciousness happened in just a few years.
It did. We trace the beginning of modern anesthesia to a few critical and often ethically messy moments. The first major attempt involved a dentist, Horace Wells.
Right, in 1844.
Yes. He tried using nitrous oxide, entered $2 but his public demonstration, it wasn't fully successful. The patient cried out.
So everyone just wrote it off.
They did. It led to widespread skepticism and, it probably delayed the use of nitrous for years.
But the breakthrough that really cracked the problem wide open came quickly after that.
Yes, the truly pivotal moment came in October 1846. Another dentist, William T.G. Morton, gave a successful public demonstration of ether anesthesia.
At Massachusetts General Hospital.
In Boston, yes. The patient successfully underwent neck surgery and famously reported feeling nothing at all. Ether just took off. It gained popularity globally almost overnight because it worked, and it was relatively safe, even if its use was prolonged and often pretty unpleasant for the patient.
And the adoption was incredibly fast, wasn't it, despite not knowing any of the long-term consequences?
Alarmingly so. Just a year after Morton's success with ether, a physician in Britain, James Young Simpson, introduced chloroform.
In 1847.
That's right. It was championed for obstetrical purposes, famously used for Queen Victoria during childbirth, but became a tremendously popular surgical anesthetic. And this was despite doctors quickly recognizing its major toxic potential.
Specifically, its effect on the heart and liver.
Yes, its cardiodepressive effects and liver toxicity were known risks. But this was a trade-off society was more than willing to make to avoid the agony of being operated on while wide awake.
So we fast forward a bit, and we get the first intravenous agent, thiopentone, in 1935. So where does modern practice stand now? We're certainly not just using ether or chloroform today.
And that gets to the absolute essence of the modern philosophy, which is balanced anesthesia.
Okay.
The idea itself is revolutionary. We recognize that asking a single drug, like ether, to achieve all four of those cardinal features, analgesia, amnesia, immobility, and reflex abolition, well, it requires an impossibly high toxic concentration of that one drug.
So instead of a single brute force drug, we use a calculated cocktail.
Precisely. We use a synergistic combination of inhaled and intravenous drugs. We might use a potent inhaled agent for unconsciousness, an opioid like fentanyl for the analgesia, and a neuromuscular blocker for the immobility.
So each drug is tailored for a specific purpose at a much lower, safer dose.
Exactly. It vastly improves patient safety by minimizing the overall toxic dose required. This philosophy is the absolute foundation of all safe anesthetic practice today.
Moving now to the molecular level, this is where the idea of the deep dive really kicks in. For a long time, the mechanism seemed almost too simple, like a general chemical fog just descending on the brain. Can you describe that initial theory?
Certainly. For many, many years, the entire field was dominated by what felt like a universal truth. The Mayer and Overton theory, which dates all the way back to 1901.
Wow, that's early.
It is. And what they observed was a stunning direct parallelism between the lipid-to-water partition coefficient of these drugs and their clinical anesthetic potency.
Let me make sure I get my head around that coefficient. It essentially measures how easily the drug moves from a watery environment, like blood, into a fatty one, like a cell membrane.
That is exactly right. The higher the ratio, the more readily it dissolves in lipid. So the theory proposed that anesthetics, being highly lipid-soluble, would just dissolve into the neuronal cell membrane.
And what would that do?
Well, the thinking was it would cause the membrane to subtly expand or change its physical structure, just kind of disrupting things on a global scale.
A simplistic metaphor might be pouring grease into a delicate machine. You just gum up the works everywhere, disrupting all communications at once.
That perfectly captures the idea of the unitary hypothesis. The drug didn't need a specific receptor. It just had to physically perturb the membrane structure and globally depress neuronal function.
So it explains why they work, but not really how they work.
Exactly. And that correlation between lipid solubility, what we call the oil-gas partition coefficient, and clinical potency, measured by MAC, it remains a powerful tool for predicting if a drug will work. But it only tells us the drug's capacity to get to the site of action, to get into that neuronal membrane. It tells us nothing about the specific molecular lock it turns once it's there.
So science moves from that global structural theory to one that is far more targeted and specific. It's no longer about gumming up the whole membrane. It's about docking onto specific protein targets.
Correct. The unitary hypothesis gave way to the agent-specific theory. We now understand that these GAs interact directly with specific hydrophobic pockets on membrane proteins, often ion channels like turning off a very precise switch, rather than tripping the main circuit breaker for the whole house.
And the most important of these switches seem to be the ligand-gated ion channels, not the voltage-sensitive ones we usually associate with, firing and action potential.
Yes. The absolute star target in this revolution is the GABA receptor gated chloride zygote channel. This is the main pathway for inhibition in the brain.
And GABA, gamma-aminobutyric acid, that's the primary inhibitory brake in the central nervous system, right?
That's the main brake, exactly. So many of our most common agents, propofol, barbiturates, benzodiazepines, and the majority of our inhalational GAs, they all work by potentiating the effect of GABA.
What does potentiating mean here?
It means they make GABA better at its job. They bind to specific sites on that receptor complex, and when they do, they enhance GABA's inhibitory effect, causing that chloride channel to open wider or stay open for longer.
So what's the physiological consequence of all that chloride rushing into the neuron?
It makes the inside of the neuron far more negative. It's a state we call hyperpolarization. Think of it this way. A neuron needs to reach a certain electrical charge threshold to fire an action potential, to send a signal. When all that negative chloride rushes in, it drives that potential further and further away from the firing threshold.
It's like putting a massive speed bump in the road.
That's a great analogy. It makes the cell much less likely to transmit any signal, effectively depressing synaptic transmission.
And that explains the suppression of consciousness and the amnesia.
Yeah.
What about the physical requirement for immobility? Where does that come in?
Well, that's thought to be tied to the effect on a similar receptor for glycine, which is the main inhibitory transmitter in the spinal cord and medulla. The potentiation of glycine channels there is believed to be crucial for blocking the motor responsiveness to painful stimuli.
So the different components of anesthesia are actually being targeted at different parts of the nervous system?
Precisely. It's not one global effect.
Now let's contrast that inhibitory pathway with agents that work on the excitatory side. Who are the outliers that don't potentiate GABA?
That brings us to nitrous oxide and
Well,
ketamine. These two are the exceptions. They operate primarily by selectively inhibiting the major excitatory pathway, which is controlled by the NMDA type of glutamate receptor.
glutamate being the accelerator, the main excitatory transmitter in the brain.
The main accelerator, exactly. The NMDA receptor typically gates a channel that lets positive ions like calcium into the cell to drive excitation. By blocking this NMDA receptor, lentityls and ketamine effectively dampen the brain's ability to excite itself. This NMDA inhibition is the primary mechanism for that unique state we call dissociative anesthesia induced by ketamine.
So we have GAs that turn up the brake, which is GABA, and we have GAs that cut the engine power, NMDA. Are there any other subtle switches involved in all this?
Yes, which just further demonstrates the complexity. There's good evidence that some GAs also activate specific potassium plus channels, known as two-pore domain channels.
And what do they do?
When these open, potassium flows out of the cell, which also causes hyperpolarization. Again, it makes the cell quieter. This mechanism is thought to inhibit the presynaptic release of transmitters entirely, acting perhaps as a fine-tuning mechanism for the overall state.
If we look at the whole picture then, GABA potentiation, NMDA inhibition, and this dollar plus dollar channel activation, what's the major takeaway about the difference between the old global depression view and the modern one?
The modern view tells us that anesthesia is not a monolithic global shutdown. It's a mosaic.
A mosaic, I like that.
Unconsciousness is achieved by suppressing the thalamus, amnesia by quieting the hippocampus, and immobility by specific action on the spinal cord. The anesthetist is using a combination of drugs to selectively target different functional axes to achieve those four cardinal features. It's not just waiting for the brain to shut down generally.
And finally, let's just solidify that key distinction you mentioned earlier, the difference between a general anesthetic and a local anesthetic.
A fundamental distinction. General anesthetics achieve their effect by depressing synaptic transmission. They block the communication between neurons at the synapse.
They stop the conversation.
Right. Local anesthetics, by contrast, work by blocking axonal conduction. They physically stop the electrical signal from traveling along the neuron's wire, usually by blocking voltage-gated sodium channels.
So one stops the conversation, the other cuts the phone line.
Perfect analogy.
That clarity on the molecular targets is fantastic. Now, let's pivot from the microscopic to the macroscopic, the visible physiological effects. For decades, the only way to reliably measure the depth of anesthesia was by using Guedel's 4 stages, which he developed back in 1920 based on the descending depression caused by ether.
Guedel's work is a classic description of how the central nervous system progressively shuts down. You lose the higher, most sensitive functions first, and the depression moves downward until, tragically, you reach the vital centers in the medulla. It's an invaluable historical roadmap, even if our modern drugs tend to obscure the physical signs.
So let's start at the beginning, with the patient inhaling the agent. What's stage 1?
Stage I is the stage of analgesia. It begins the moment the patient starts inhaling the anesthetic, and it ends the moment they lose consciousness. During this time, pain is progressively abolished. The patient might feel euphoric, maybe in a dreamlike state, but they are still conscious and capable of responding to commands. Amnesia develops towards the very end of this stage.
So consciousness is maintained, but sensation is dulled. But then things get dangerous.
Then you hit the infamous stage 2, the stage of delirium or excitement. This stage is very short in modern practice, thank goodness, but historically it was a terrifying period. It starts with the loss of consciousness and ends when respiration becomes regular and rhythmic.
And what's it characterized by?
It's marked by involuntary and often violent movements. Struggling, breath holding, shouting, increased muscle tone. The jaws may even clamp shut.
The danger is not just the movement, but the physiological storm that's happening inside, right?
Exactly. This is pure sympathetic stimulation. Heart rate and blood pressure increase sharply. The pupils dilate. Clinically, this is the stage of maximum risk for aspiration or laryngeal spasm.
So this is why every anesthetist is trained that under no circumstances should a painful stimulus or the operation itself begin during stage 2.
Never. Modern pre-medication is specifically designed to bypass this chaotic phase as quickly and smoothly as possible.
Once we pass that stage and breathing stabilizes, we reach the therapeutic target. Stage 3, surgical anesthesia. Now, Guedel divided this into 4 planes, based largely on eye movement and reflexes.
That's right. Plane 1 of stage 3 starts when the breathing becomes regular and the key visible sign is roving eyeballs.
Mm.
They are moving slightly beneath the closed lids. Plane 1 ends when those eyes become fixed.
Then as you go deeper,
As the depth increases into plane 2, you see the loss of key protective reflexes, specifically the corneal reflex blinking when the cornea is touched and the laryngeal reflex.
and further down, the body systems start to profoundly decline.
Plane 3 is the deeper state where the pupil begins to dilate and its reaction to light is lost. Respiration becomes shallower. And finally, plane 4 is the deepest acceptable state. Intercostal paralysis begins, which means the patient is now relying only on their diaphragm for abdominal breathing. This is the last safe stop before disaster.
Which brings us to the final unavoidable destination if things go wrong. Stage 4, medullary paralysis.
This is failure. This is cessation of breathing, total flaccid muscles, followed by complete circulatory failure and death. The physiological depression has reached the brainstem, which controls all the autonomic centers necessary for survival.
As fascinating as Guedel's stages are, they relied on a single, slow-acting drug like ether without any of our modern adjuncts. Since we use fast 5e induction agents, muscle relaxants, and pre-medication today, these clear signs, the roving eyeballs, the delirium, and they're largely obsolete, aren't they?
That's the clinical reality. Modern anesthetists rely on electronic monitoring blood pressure, heart rate, end-tidal TEX-KO22, oxygen saturation, all monitored continuously. And we rely on more subtle, immediate physical indicators.
So if the 4 planes are obscured, what are the reliable signs of depth today? How do you know you're in stage 3?
We use immediate reflexes. If the eyelash reflex is present or if the patient is making swallowing movements, they're still too light, still potentially in stage 1 or transitioning to 2. The sign we look for to confirm entry into stage 3 is the loss of response to a painful stimulus, which we usually test with a specific pressure on the patient.
And what about the other way? What are the common warning signs that the patient is starting to surface, getting too light in the middle of a procedure?
These are reflex physiological responses to the surgical pain. The patient might show a sudden, unprompted increase in their respiration or blood pressure. They might start to fight the ventilator or cough, or very subtly, their eyes might begin to tear up.
And if the anesthesia is too deep,
The signs are purely depressive. A marked, rapid fall in blood pressure, significant cardiac depression, and often a profound drop in core body temperature. You're constantly walking this tightrope.
this precise need for control leads us to the universal standard for measuring the potency of inhaled agents, the MA concept.
MA, or minimal alveolar concentration, is absolutely fundamental. It is the gold standard for comparing one inhaled agent to another.
And how is it defined?
MAC is defined as the concentration of the anesthetic in the pulmonary alveoli that is needed to produce immobility in response to a surgical incision in 50% of individuals.
It's a measure of potency, but also critically it's a measure of safety, given the steep dose-response curve you mentioned earlier.
That's the terrifying precision of this field. For most young adults, the dose-response relationship is extremely steep. If one MAC immobilizes 50% of subjects, you only need about a 30% higher concentration, 1.3 MA, to immobilize 95% of subjects.
That is a narrow window.
It's an incredibly narrow therapeutic window. While we aim for roughly 1.0 to 1.5 MAT key for maintenance, concentrations exceeding 1.5 MAT are rarely tolerated, and a patient inhaling 2 to 3 MAC for any sustained period is often lethal.
And conversely, what does that tell us about recovery? When does the patient wake up?
It tells us exactly when. Anesthetized subjects reliably regain consciousness when the anesthetic concentration in their alveoli falls to roughly 0.4 MAC. That's the level of pharmacological precision we're dealing with.
Before we move on, are there common physiological impacts that pretty much all potent inhalational GAs share?
They all affect the central nervous system in predictable ways. As you increase the concentration, you see progressive EEG suppression, which eventually leads to electrical silence above 2 MAC. They all decrease the brain's metabolic rate, which is good, but they also cause peripheral vasodilation, which means that at high concentrations, their direct actions can sometimes actually increase cerebral blood flow. And this is a crucial concern for patients with raised intracranial pressure, where we have to rigorously avoid deep anesthesia.
And what about the heart and lungs?
All potent fluorinated anesthetics depress cardiac contractility and lower blood pressure to varying degrees, and all of them cause respiratory depression. On the positive side, they are bronchodilators, which is useful, but they also reduce mucociliary function in the airways, which can predispose patients to respiratory complications after long procedures. You're constantly managing these trade-offs.
We've established the mechanism where the drug works and the effect, the stages of depression. Now, we have to understand the how fast the pharmacokinetics. This is all governed by how the drug moves through the body, focusing on that gas tension or partial pressure in the brain.
That's right. The depth of anesthesia is directly proportional to the partial pressure in the brain. So induction and recovery hinge entirely on the speed at which we can change that partial pressure, moving the drug across three critical tension gradients, from the alveoli to the blood to the brain.
So let's identify the factors that govern the rate of delivery from the machine to the blood.
Okay, we have three primary rate determining factors. First, the easiest one to control, the inspired partial pressure. If you increase the concentration in the mask, you crank up the concentration gradient, pushing the drug into the blood faster, which of course hastens induction.
Second is the patient's breathing efficiency or pulmonary ventilation.
Hyperventilation acts like flooring the gas pedal. It rapidly delivers more anesthetic to the alveoli, speeding induction. Conversely, respiratory depression, maybe from premedication or pain, dramatically slows the whole process. This effect is most pronounced for agents that have a high solubility in the blood, where the blood's partial pressure would otherwise take a long time to rise.
And the third factor is how efficiently the lungs are exchanging gas in the first place, or alveolar exchange.
If a patient has a lung condition like emphysema, you get what we call a ventilation-perfusion mismatch. Areas of the lung might be well perfused with blood, but they're poorly ventilated with gas. This poor exchange means the drug gets diluted in the overall blood pool, which slows down both induction and recovery equally.
But the truly critical inherent factor that determines the speed of any given agent is its solubility in the blood, measured by the blood, gas partition coefficient. This is where we need to spend some time, as it explains the clinical experience of every single drug.
This coefficient is the single most important predictor of speed. Think of the blood as a sponge. The coefficient tells you how absorbent that sponge is. If the coefficient is high, the blood is a very absorbent sponge. It needs to soak up a huge amount of drug before the blood's partial pressure, and thus the brain's starts to rise.
Let's use the extremes. What does a high coefficient tell us clinically?
Okay, take ether. It has a coefficient of 12.1. This is extremely high solubility. The blood must dissolve a massive amount of ether before its partial pressure reaches equilibrium with the inspired gas. Clinically, this translates to a very slow, often unpleasant, and prolonged induction and recovery. That's the infamous ether hangover.
Now contrast that with the modern rapid agents.
Look at agents with low solubility. Nitrous oxide, which we know is fast, has a coefficient of 0.47. Desflurane is even lower at 0.42. Since the blood sponge absorbs very little of the drug, the blood's partial pressure rises almost immediately, hitting equilibrium very quickly,
Which means fast induction.
and near instant recovery once the gas is turned off.
So solubility is everything. Low solubility equals fast in and fast out.
But we also have to look at tissue solubility, measured by the oil-gas coefficient, because that determines the length of recovery after a very long surgery. Highly lipid-soluble anesthetics, like halothane, which has an oil-gas coefficient of 224, will continue to dissolve into adipose tissue for hours because they are so lipophilic.
And all that stored drug eventually has to come back out, which prolongs recovery.
Exactly. After prolonged procedures, these highly soluble agents build up significant depots in muscle and fat. As the inspired concentration falls to zero, these depots slowly release the drug back into the blood, delaying full recovery and sometimes causing that residual CNS depression or mental fogginess for 24 to 48 hours. This is the halothane or isoflurane hangover.
Once the anesthetic is stopped, how is it eliminated from the body?
For most inhaled agents, elimination is primarily through the lungs. You're just reversing the gradient. The drug leaves the blood, enters the alveoli, and is exhaled.
What about metabolism? Are they all chemically inert?
No, and this is a critical point when we talk about toxicity. Most modern agents are engineered to be minimally metabolized. However, halothane is the major exception. Over 20% of it is metabolized in the liver. And this high rate of metabolism is directly linked to the risk of that rare but serious delayed liver toxicity hepatitis that we discussed earlier.
Finally, we noted that nitrous oxide's unique low solubility creates two specific clinical phenomena during recovery.
Right. These are the second gas effect and diffusion hypoxia. Because complex is so rapidly absorbed during induction, it effectively concentrates the other gases, like the primary volatile agent, in the alveoli, which speeds up their absorption. That's the second gas effect.
And the other side of that coin.
Conversely, at the end of surgery, when you stop the alveoli, it rushes down the blood into the alveoli so quickly that it transiently dilutes the oxygen and carbon dioxide concentrations there.
And that's dangerous.
It can be. If you switch the patient straight back to breathing normal room air, this can cause a brief but dangerous period of diffusion hypoxia. So modern anesthetists have to ensure the patient breathes 100% oxygen during this recovery phase to prevent that from happening.
With the mechanisms and kinetics established, we can now look at the specific agents. The choice of agent is often a trade-off between potency, speed, and cardiovascular stability. Let's start with our low-potency adjuvant, nitrous oxide.
And $1 is foundational, but it's limited. It's cheap and pleasant to inhale, but its extremely low potency means its MAC is 105%. You cannot achieve surgical anesthesia even with 100% $9 at standard atmospheric pressure.
So its main role is as a helper.
Yes, as a carrier gas and an adjuvant. We typically use a mixture of 70%, 30% $9, and combine that with a potent volatile agent. By using $NA, you can reduce the required MAC of the cardiodepressant volatile agent by about 1/3.
So it's a safety tool. It lets you use less of the more toxic primary drug.
Precisely. Another major benefit is its surprising analgesic quality. A 20% concentration provides pain relief that's equivalent to a standard dose of morphine. And, of course, because of its low blood solubility, induction and recovery are extremely fast.
What are the clinical drawbacks that limit its use?
Well, it provides minimal muscle relaxation, so it's ineffective alone for surgery. The biggest risk is diffusion. Because it diffuses into air pockets faster than nitrogen can leave, it can expand and close spaces in the body.
So if a patient has a pneumothorax,
Or a bowel obstruction, or even just an air bubble in the middle ear, your dollars will rapidly expand that pocket, which can be catastrophic.
and what about the risk of prolonged use?
Long-term exposure, which you might see in chronic pain management or among unventilated operating room staff, can lead to depression of bone marrow and peripheral neuropathy. This is thought to be due to an irreversible oxidation of the cobalt in vitamin text, which effectively knocks out the essential enzyme methionine synthase.
Moving to the volatile liquids, halothane was the standard for decades, but it's now often relegated to developing countries. Why did it fall out of favor in the affluent world?
Halothane was a huge improvement in 1956. It's sweet-smelling, non-irritant, non-flammable, which made induction pleasant. But its deficiencies are primarily cardiovascular. It's a direct and potent myocardial depressant.
How does it do that?
It reduces intracellular calcium concentration, which directly decreases the heart's contractility. This means cardiac output drops as anesthesia deepens and blood pressure falls significantly.
And what about the risk of arrhythmias?
That was the second major cardiotoxicity. Halothane sensitizes the heart muscle to the arrhythmogenic action of adrenaline or catecholamines. So if the patient is stressed or the anesthesia is too light, the body releases adrenaline, which can trigger dangerous re-entry tachyarrhythmias.
We have to elaborate on malignant hyperthermia, or MH. This is the great risk associated with halothane and certain other triggers.
MH is a dramatic, rare, genetically determined crisis. Susceptible patients have an abnormality, often in the RIR1 or ryanodine calcium channel in their skeletal muscle. When they're exposed to halothane or the muscle relaxant succinylcholine, this channel opens uncontrollably, causing a massive, sustained intracellular release of calcium.
Which leads to what physiological effect?
Persistent muscle contraction, extreme rigidity, rapid oxygen consumption, massive TEC-CO2 production, and a rapid, uncontrolled rise in body temperature, sometimes reaching 43 degrees Celsius.
It's a metabolic furnace running wild.
That's a perfect description.
What is the immediate life-saving treatment for an MH crisis?
You have to immediately stop the trigger agent, use rapid external cooling and 100% N2, and administer intravenous dantrolene. Dantrolene acts directly on the muscle cell to inhibit the further release of calcium from the sarcoplasmic reticulum. It is the specific antidote.
Given halothane's toxicity and the risk of rare hepatitis due to its high metabolism, it has been largely superseded by isoflurane, the routine standard since the 1980s.
Isoflurane is much safer. It is less potent and less soluble than halothane, making induction and recovery slightly faster. Clinically, it's a very stable, reliable agent.
And how does its cardiovascular profile compare?
Far superior. While isoflurane still causes a drop in blood pressure, this drop is mainly due to vasodilatation opening up the blood vessels, not severe myocardial depression. Cardiac output is usually well maintained, making it the agent of choice for patients with compromised heart function. And crucially, it does not sensitize the heart to arrhythmias.
And its specific niche in neurosurgery.
Isoflurane does not provoke seizures, which makes it safe for patients undergoing neurosurgical procedures. Its primary mild drawback is its pungent, ether-like odor, which can irritate the airway slightly, making it less pleasant for induction by face mask.
That leads us directly to the two high-end, fast-acting modern agents, desflurane and sevoflurane. Let's tackle desflurane first. Why is it considered the fastest agent available?
Desflurane is the champion of speed, and it comes down entirely to kinetics. It's blood. Gas partition coefficient is the lowest of them all, at just 0.42. This minimal solubility means it equilibrates between the machine, the blood, and the brain almost instantly.
So it's perfect for outpatient surgery.
It's the agent of choice for outpatient surgery, where quick discharge and minimal residual cognitive impairment are paramount.
But it comes with a major physiological cost.
Yes. Because its potency is so low, it's about 1/5 as potent as isoflurane, the concentration required is very high. This high concentration, combined with its chemical structure, makes it highly irritating to the airway, which can trigger coughing, breath holding, and a dangerous complication called laryngospasm during induction.
So you're telling me we use this super irritating gas just because it's fast?
For certain procedures, yes. And there's another issue. Rapid changes in the delivered concentration can cause a brief, intense sympathetic stimulation, leading to tachycardia and hypertension. This makes it risky for patients with severe coronary artery disease.
So we tolerate the irritation and the price for its sheer speed, primarily in healthy outpatients. That leaves sevoflurane. How does it fit into the landscape?
Sevoflurane strikes a really nice balance. Its solubility and potency are intermediate. It's faster than isoflurane, but slightly slower than desflurane. But its key advantage is the absence of pungency.
So it doesn't irritate the airway.
It's pleasant, smooth, and non-irritating, which makes it the absolute agent of choice for face mask induction, especially for children who cannot cooperate with 5E placement.
Why isn't sevoflurane universally used if it's so pleasant and fast?
Cost is one major barrier. It's expensive. Second, it has a chemical quirk. It reacts with soda lime, the carbon dioxide absorbent used in closed breathing circuits, to form trace amounts of toxic compounds. While this risk is manageable, it means sevoflurane is not recommended for use in fully closed circuits, which limits its flexibility in some settings.
Moving to the IV agents, these drugs are the cornerstone of induction because they can achieve loss of consciousness in the time it takes for one arm-to-brain circulation, which is roughly 11 seconds.
IV induction is what ensures the patient skips that difficult and dangerous stage to delirium completely. They are used for rapid induction, followed by an inhalational agent, or as part of what we call total IV anesthesia, or TIVA, where the entire procedure is maintained using IV infusions, eliminating the need for volatile gases entirely.
Let's start with the agent that defined the rapid IV start, thiopentone sodium.
Thiopentone is an ultra-short-acting barbiturate. Its action is virtually instantaneous unconsciousness in 15-20 seconds, and that's due to its incredibly high lipid solubility. It just penetrates the blood-brain barrier with astonishing speed.
Now, here's the crucial distinction that often confuses people. A single dose wears off in 6 to 10 minutes, yet its elimination half-life is 8 to 12 hours. Why the massive difference?
The termination of its clinical action has absolutely nothing to do with how quickly the body breaks it down. It's entirely due to redistribution.
Okay, what does that mean?
After that rapid initial spike in the brain, the highly concentrated drug starts leaking back out of the highly vascular brain and redistributes into less vascular tissues, primarily muscle and fat. As the concentration in the brain falls, consciousness is regained.
Hang on, so recovery is fast because the drug has simply moved elsewhere in your body, not because it's been eliminated?
Exactly. The body hasn't metabolized much of it at all yet. And since its actual metabolism is slow, residual CNS depression, or that lingering barbiturate fog, can persist for many hours, which limits mobility and alertness postoperatively.
And its lack of analgesic properties was a major clinical limitation.
Absolutely. Thiopentone provides very poor analgesia. If a painful procedure was attempted with only light thiopentone, the patient would struggle and show marked reflex responses, proving that it only provided amnesia, not full anesthesia. It has been largely replaced in modern practice.
The agent that replaced it and the current IV standard globally is propofol.
Propofol is a game changer. It's an oily liquid emulsion that gives a smooth, rapid induction in 15 to 45 seconds, lasting about 5 to 10 minutes. Crucially, unlike thiopentone, propofol is rapidly metabolized. Its short elimination half-life of about 100 minutes means the patient recovers much faster, with far less residual impairment.
And this rapid clearance is why it's so ideal for outpatient surgery, allowing patients to get home sooner.
Precisely. Its mechanism, enhancing GABA inhibition, is similar to many volatile agents. Clinically, it's preferred because it lacks airway irritancy, making it safe for asthmatics, and it has a nice bonus. It also has strong antiemetic properties, which reduces postoperative nausea.
What's the primary caution with propofol?
It causes a profound, albeit short-lasting, fall in blood pressure, which is more marked than with thiobentone, mostly due to vasodilatation. This requires very careful titration, especially in elderly or hypovolemic patients.
Next, we move to the outliers, agents that induce a completely different state, exemplified by ketamine. This is the drug of dissociative anesthesia.
Ketamine is unique. It's related chemically to phencyclidine, the hallucinogen, and it induces a state where the patient achieves profound analgesia and immobility with only light sleep. The word dissociative is perfect because the patient appears, well, separated from their body and their surroundings.
How does the patient look during this state? It sounds almost unconscious but conscious.
It's startling for the uninitiated. The patient may look conscious, their eyes might be open, they might make swallowing movements, and their muscles might even be rigid, what we call cataleptic, but they are totally unaware of any sensory stimuli or their surroundings.
And this is because it works by inhibiting those excitatory NMDA receptors.
Exactly. It's blocking the perception pathways rather than globally depressing the brainstem like barbiturates do.
What are its unique hemodynamic benefits?
It does the opposite of propofol. Ketamine does not depress respiration and can actually maintain or even improve airway reflexes. Crucially, it stimulates the sympathetic nervous system, causing a rise in heart rate, cardiac output, and blood pressure.
That makes it a fantastic tool for specific situations.
It is invaluable for hypovolemic patients, for example, trauma victims in the emergency room who are hypotensive due to blood loss. It helps maintain their cardiovascular function, where propofol or halothane would cause a total collapse. Conversely, it's dangerous for patients with pre-existing high blood pressure or ischemic heart disease.
And the recovery. That's where the side effects show up.
The main drawback is the risk of emergence phenomena. Up to 50% of adults experience vivid dreams, hallucinations, or fear reactions as they wake up, sometimes described as a terrifying detachment from reality. This is why ketamine is often given with a benzodiazepine to mitigate these psychological effects.
Finally, let's examine the role of opioid analgesics, which are often used simply to supplement the primary anesthetic.
Opioids are essential in balanced anesthesia because they achieve that crucial first goal, analgesia or pain relief. Fentanyl is a common example. It's highly lipophilic and short-acting, lasting 30 to 50 minutes. By using fentanyl, the anesthetist can dramatically lower the concentration of the inhaled agent needed to abolish the reflex effects of pain, improving overall hemodynamic stability.
Fentanyl's primary risk is respiratory depression.
Marked respiratory depression is the primary side effect, alongside a tendency to cause bradycardia. The other major clinical risk, especially when fentanyl is used alone with BZDs for conscious sedation, is anesthetic awareness. The patient feels pain but cannot move or speak.
The ultimate tool in this class, however, seems to be remifentanil.
Remifentanil represents pharmacokinetic perfection for an analgesic. It is an ultra-fast-acting congener whose action fades reliably in just 10 to 15 minutes, even after a prolonged, continuous infusion. This predictability is its superpower.
And why is it so predictable regardless of the duration or the patient's health?
Because its rapid metabolism is carried out by nonspecific plasma and tissue esterases that are found everywhere in the body, not by the liver or the kidney. Therefore, patients with liver failure, kidney failure, or those who have been on the infusion for hours metabolize it at the same predictable rate. This makes remifentanil the ideal agent when immediate precise control and rapid postoperative pain fading are required.
We've covered the agents for induction and maintenance, but the patient's entire experience begins before they even enter the operating room with pre-anesthetic medication or pre-medication. This is the toolkit used to maximize safety and patient comfort.
Pre-medication is a strategic part of the overall anesthetic plan. It's designed to address risks, anxiety, and side effects before they even have a chance to manifest. We have 6 primary goals here.
Let's detail those goals and discuss how we achieve them. The first 2 are psychological.
First, we aim for the relief of anxiety and apprehension. A calm patient requires less anesthetic. Second, we aim for amnesia for perioperative events. The patient should ideally not remember the IV start, the mask placement, or the transfer to the operating table.
The drug class that achieves both those goals best is the benzodiazepines, or BZDs.
Yes, they produce tranquilizing effects and potent amnesia with minimal respiratory depression. We use drugs like diazepam, lorazepam, or midazolam. In modern clinical practice, midazolam is highly preferred over the others.
Why the preference for midazolam?
Midazolam is water-soluble, which means it is non-irritating when it's injected into the vein. But crucially, it is faster and significantly shorter acting than diazepam. This rapid onset and quick clearance make it ideal for pre-procedure anxiety and also for continuous sedation in critical care settings.
Next, we address two more physical goals: supplementing analgesia and decreasing secretions and vagal stimulation.
For supplementing analgesia, we often use an opioid like fentanyl in the pre-medication phase, which means less volatile agent is required during the procedure. For decreasing secretions and preventing vagal stimulation, we rely on anticholinergics like atropine or glycopyrrolate.
These were historically necessary to dry up the copious secretions caused by older irritant agents like ether. Why are they still necessary today?
Their modern role is really prophylactic, preventing dangerous autonomic reflexes. Vagal stimulation caused by things like intubation or manipulation of abdominal viscera during surgery can cause severe bradycardia and hypotension. Anticholinergics prevent this. They also prevent laryngospasm, which can be triggered by even minor secretions hitting the vocal cords.
And is one preferred over the other?
Glycopyrrolate is generally the preferred antimuscarinic agent. It is twice as potent, longer acting, and most importantly, it does not cross the blood-brain barrier. This prevents the central effects like disorientation or delirium that older drugs like hyoscine could cause.
The final two goals are crucial safety steps: an antiemetic effect and gastric management. Let's start with managing the risk of aspiration.
This is critical. Patients must be fasted before surgery, but anyone undergoing prolonged surgery, emergency surgery, or those with underlying risk factors like obesity or pregnancy are at increased risk of regurgitating stomach contents into their lungs. This causes aspiration pneumonia, which is highly damaging because stomach acid destroys lung tissue.
So we use drugs to reduce the volume and raise the pH of the stomach acid.
Exactly. We routinely use 2H2 blockers like ranitidine or proton pump inhibitors, PPIs, like omeprazole. The goal is twofold: increase the pH to above 3.5 and reduce the volume of gastric juice to less than 25 milliliters. Meeting those thresholds significantly reduces the risk of serious lung damage if aspiration does occur.
And finally, addressing post-operative nausea and vomiting, or PONV.
PONV is miserable for the patient, and it can delay their discharge. It is prevented using antiemetics, and the drug of choice today is usually ondansetron, a selective $5 HT3/3A3 blocker. It's highly effective and has an excellent safety profile.
Let's pivot to the complications. We've discussed malignant hyperthermia, but what are the most common acute complications that must be guarded against during the surgery itself?
Acute complications include respiratory depression, leading to hypercarbia, which is high-text TOT2, cardiac arrhythmias, and of course, aspiration and laryngospasm. All anesthetists are constantly vigilant for these shifts.
But the
Awareness is the patient's dreadful perception and recall of events during the procedure. It is a genuine surgical nightmare. It occurs when anesthesia is too light, but the patient is often paralyzed by a neuromuscular blocker. They cannot move, they can't scream, they can't signal their consciousness, yet they can perceive the pain, the conversation, and the entire surgical trauma.
Why does this happen, even with modern monitoring?
It typically happens when the anesthetist is deliberately running a very light level of anesthesia, perhaps for a fragile cardiac patient, where a deep dose would cause circulatory collapse, while relying heavily on a muscle relaxant to ensure immobility. It is a fundamental failure of the balanced anesthesia technique if the amnesic component fails while the paralytic is working.
The psychological trauma must be immense.
It can lead to severe post-traumatic stress disorder or PTSD. New monitoring technologies such as EEG processing to measure depth of anesthesia have been developed specifically to try and mitigate this risk.
Post-anesthetic issues also linger: the persistent sedation, nausea, and vomiting.
Yes. Depending on the agent, residual sedation can impair psychomotor function for up to 12 hours. Patients need clear instructions about not driving or signing legal documents. And rare but devastating toxicities, like liver damage from halothane, remain a concern, although they're far less common with our modern agents.
Finally, we must note the crucial drug interactions, as patients rarely come in completely healthy.
The primary interaction is hemodynamic. Patients taking antihypertensives, blood pressure medication, are at high risk of a sudden dangerous fall in blood pressure when they're given GAs, requiring precise and often immediate management.
And what about the management of chronic corticosteroid users?
This is absolutely critical. Anesthesia and surgery represent a profound physiological stressor. Patients on long-term corticosteroids have suppressed adrenal function and cannot produce the necessary stress hormones like cortisol to cope with the procedure.
Through what happens?
If they're not given supplemental hydrocortisone intraoperatively, they risk acute adrenal insufficiency and potentially fatal cardiovascular collapse. It's a non-negotiable step in their management.
We started this deep dive with the horror of pre-19th century surgery and have tracked the evolution to a place of ultimate pharmacological control. The transition from the single-agent, uncontrolled Guedel stages to today's highly synergistic approach, balanced anesthesia, is really a triumph of chemical precision.
It truly is remarkable. We've established that the speed of an agent is governed by the simple elegance of its blood, gas solubility coefficient, with low solubility equating to rapid action. And the mechanism is a precise chemical attack on specific receptors, potentiating GABA for unconsciousness, inhibiting NMDA for dissociation, and using opioids for powerful analgesia.
The anesthetist today is not simply causing sleep, but executing a highly specific, tailored, and reversible suppression of different functional axes. The right drug for amnesia, another for immobility, and a third for pain. The complexity is controlled.
The level of safety is completely dependent on this control. And that tight, nonlinear control brings us to our final provocative thought for you to consider.
We've seen how narrow that therapeutic window is, recovery occurring around 0.4 MSC, yet 2 to 3 MSC being lethal. Given this incredibly steep dose-response curve, how does the subtle difference between conscious sedation, where the patient maintains communication and protective reflexes, and general anesthesia, fundamentally change the ethical and physical boundaries of surgical intervention?
It forces us to ask, at what exact point does the chemical manipulation eliminate the patient's autonomy? And how must that definition change as our technology allows us to achieve increasingly dissociative states, such as with ketamine, where the body is mobilized and analgesic, yet the brainstem remains active?
Something to ponder as you reflect on everything we've covered in this deep dive. Thank you for joining us.